Welcome back to The Explainer. Today, we're running a masterclass clinical case review on hirsutism and hyperandrogenism. If you've ever felt completely overwhelmed by that dizzying array of lab thresholds and endocrine pathways, trust me, you're not alone, and you're in exactly the right place. We're going to lock down the exact diagnostic criteria you need to differentiate causes of hirsutism and absolutely crush these concepts on your boards and during clinical rotations. Let's jump right in.
Okay, so picture this classic board presentation. You've got a female patient presenting with rapid onset virilization, and her total testosterone level is sitting at 14 nanomoles per liter. So, what's the most likely diagnosis? I want you to keep this high-yield question right in the back of your mind as we work through our diagnostic funnel today. By the end of this explainer, the answer is going to be second nature to you.
Here's our roadmap for the workup. We'll hit defining the chief complaint, look at mechanisms of androgen action, formulate the differential diagnosis, dive into high-yield diagnostic thresholds, and finish up with evidence-based management pathways.
All right, kicking things off with Section 1, defining the chief complaint.
Now, we have to get our terms straight right out of the gate, because mixing these up on the boards will send you straight down the wrong differential. This is a super highly tested distinction. Hirsutism is strictly androgen-mediated. It's that growth of coarse, terminal hair in sex-specific areas. You know, the face, chest, or upper back. Hypertrichosis, though, that's completely androgen-independent. It's just generalized excess hair growth literally anywhere on the body, and it's heavily tied to the patient's medication history. So if your vignette casually drops a drug like phenytoin, minoxidil, or cyclosporin, boom, you're dealing with hypertrichosis, not hirsutism. Always keep your eyes peeled for those medication clues.
But what happens when things go beyond just hair growth? Well, that brings us to virilization. If you see signs of virilization in a case, we're talking voice deepening, clitoromegaly, or temporal balding, this is a massive red flag. It signals severe, profound androgen excess. This should immediately shift your clinical suspicion away from those calming mild conditions and straight toward an androgen-secreting tumor or severe hypertrichosis.
So the magic number here is 8. In the clinic, we use the modified Fairman-Galway scale, which grades hair growth across 9 body areas. A score over 8, that indicates excessive androgen-mediated hair growth, meaning true hirsutism in about 95% of non-Hispanic white and African-American women. Just a quick aside though, baseline scores really vary by ethnicity. So Asian or Native American patients might present with severe androgen excess, but actually score below an 8. Keep that context in mind.
Moving right along to Section 2, mechanisms of androgen action. To effectively treat the problem, we first have to understand the cellular mechanics and the sources of circulating androgens in women. They're split right down the middle, literally 50-50. 50% originate from the ovaries and 50% come from the adrenal glands. This even split is exactly why our diagnostic workup has to evaluate both potential sources when we're hunting for the root cause of hyperandrogenism. It's like a giant puzzle, and you need to check both sides of the board.
Now, end organ sensitivity really matters here. At the level of the pilosebaceous unit, the PSU, testosterone is basically just a prohormone. It gets converted locally into DHT, which is the heavy hitter driving that hair growth. The enzyme pulling the strings is 5-alpha reductase. But here's a classic board prep trick for you. Type 1 predominates in the skin and PSU, while type 2 is hanging out in the prostate. Finasteride selectively targets type 2. So because type 1 dominates the skin, finasteride has extremely limited efficacy for hirsutism. Seriously, do not pick it as your first-line answer for body hair.
All right, Section 3, formulating the differential diagnosis. Now that we know the mechanics, let's round up the usual clinical suspects. When building your differential, pay close attention to the stark contrasts. On one hand, you've got PCOS, which accounts for about 75% of ovarian causes. It shows up as a steady, chronic condition with oligomenorrhea and a modestly elevated testosterone, usually under 7. Contrast that with an androgen-secreting tumor. The hallmark there? Sudden onset, rapid progression, severe virilization, and sky-high testosterone. And hey, don't forget idiopathic hirsutism. It's actually the most common diagnosis overall, and it's characterized by entirely normal labs and normal menses. Wild, right?
Next up, Section 4, high-yield diagnostic thresholds.
We've got our clinical clues, but we need hard data. Pay close attention to this specific threshold. A total testosterone level greater than 12 nanomoles per liter is a massive, screaming red flag. It almost definitively points to an androgen-secreting tumor, and that demands urgent imaging. By the way, in standard US units, that translates to greater than 3.5 nanograms per milliliter.
When you see this number on a test or in a real patient, your immediate next thought has to be, where is the tumor?
For the boards, you're going to use these rule-out logic thresholds to guide your next steps. If total testosterone is over 7, it's highly suggestive of a tumor or hyperthecosis, so you order a transvaginal ultrasound to check those ovaries. If DHES is greater than 18.5 micromoles per liter, well, that crosses the specific threshold for an adrenal tumor, meaning you need an adrenal CT or MRI. But what if the testosterone is in that overlapping 2 to 7 range? That's when you have to dig a little deeper. You'll check free testosterone, SHBG, and start differentiating PCOS from non-classic congenital adrenal hyperplasia.
Speaking of non-classic CAA, this is the exact algorithmic workflow you absolutely must follow to rule it out. Step 1. Draw a morning follicular phase basal 17-OHP. If it's less than 6 nanomoles per liter, boom, you're done. 21-hydroxylase deficiency is effectively excluded. But if it falls in that murky borderline range of 6 to 30, you've got to proceed to the ACTH stimulation test. A 1-hour post-ACTH level soaring above 30 to 45 confirms the diagnosis. Memorize this sequence, it comes up all the time.
And if you need to isolate the exact source of that excess androgen, remember that 50-50 split we talked about earlier? The dexamethasuppression test elegantly splits the adrenal versus ovarian pathways. Here's how it works. You administer a low dose of dexamethasone for 4 days. If the excess androgen is coming from the adrenal glands, the dexamethasone suppresses ACTH and the free testosterone drops right back down to the normal range. But if it's an ovarian source, like severe hyperthecosis or a tumor, you're going to see incomplete suppression. That testosterone is going to stubbornly remain elevated.
Finally, we hit Section 5, Evidence-Based Management Pathways.
We've formulated our diagnosis using the right thresholds, so what's the game plan? Combined oral contraceptives, or COCPs, are your absolute first-line pharmacological treatment. Why? Well, because the estrogen component beautifully increases sex hormone-binding globulin, or SHBG. Think of SHBG like a giant molecular sponge that literally traps free circulating testosterone, making it biologically inactive. But managing patient expectations is so vital here. While you can expect a really fantastic 50% improvement in acne, you're generally only going to see about a 20% reduction in hirsutism with OCPs alone. But we have to anchor this knowledge to actual clinical action. Listen, not all OCPs are created equal. You must actively avoid prescribing highly androgenic progestins like norgestrel or levonorgestrel for a patient with hirsutism. These older progestins will actually blunt the estrogen-induced rise in SHBG. Basically, they worsen the free testosterone levels and actively work against your entire treatment goal. Don't fall into that trap.
Now, if OCPs just aren't cutting it after several months, we escalate to anti-androgens. Spironolactone is highly effective, just make sure you're monitoring their potassium and blood pressure. And crucially, dutasteride outperforms finasteride here. Remember our discussion on those enzyme mechanisms? Dutasteride blocks both type 1 and type 2 enzymes, effectively shutting down DHT production in the skin where type 1 lives. Finasteride only blocks type 2, making it pretty useless for body hair, though decent for scalp hair loss. Lastly, while flutamide is a super potent androgen receptor antagonist, you must avoid it due to severe hepatotoxicity. It's a classic distractor answer on exams, so watch out.
Whenever you kick off these treatments, you have to counsel your patients using this specific timeline. The hair cycle has a really long resting phase, known as the telogen phase. Because of this biology, visible improvements in hair growth just aren't going to show up for at least 4 to 6 months. It actually takes a full 9 to 12 months to see the maximum pharmacological effect. If you skip explaining this, your patient is going to think the drug is a dud and abandon the therapy at month 2.
And there is no way we can end a discussion on anti-androgens without a massive safety warning. Spironolactone, finasteride, and dutasteride all carry a severe teratogenic risk. They can literally cause the feminization of a male fetus if the patient becomes pregnant. Because of this, concurrent use of highly effective contraception like the OCPs we just talked about is absolutely mandatory when prescribing these meds, no exceptions.
So, bringing it all the way back to our opening clinical vignette, we have a patient presenting with rapid virilization and a total testosterone greater than 14 nanomoles per liter. Based on those extreme thresholds we mapped out, we know it's an androgen-secreting tumor. But here is the question you need to be ready for when your attending starts grilling you. What is your immediate next step to locate that tumor? Do you start with an ovarian transvaginal ultrasound, or do you jump straight to an adrenal CT? Look back at those DHES and testosterone thresholds we discussed to justify your choice. Think it through, trust the pathways we built today, and keep mastering the medicine. Catch you on the next one.